Welcome back to Mapping Healthcare on KDRT 95.7 FM in Davis, California, where a medic with a map explores healthcare around the world, highlights people who improve it, and shares what we can learn from them. This is your host, Dr. Sheikh. You're in a hospital, maybe the maternity ward. It's a busy and high-stress place. The nurse is getting your medication ready. But here's the thing. The epidural bag, the one with the really strong painkiller, it looks almost exactly like a standard IV bag. And worse, the connectors, they fit both lines. So imagine a brief moment of distraction, maybe fatigue. The nurse connects the wrong bag, it's a potentially fatal error, and it's actually happened. Or maybe you're a clinician in the intensive care unit and your patient crashes. The code blue team rushes in, they grab the defibrillator pads, but the pads don't connect to the defibrillator. There's a different brand of pads in this ICU than in the rest of the hospital. It's a system failure right when you need the system to work the best. These aren't just mistakes or someone not paying attention. They're stark examples of how technology, procedures, and just being human can collide with disastrous results. So the big question is, why does this keep happening? And why do we jump to blaming the human when the system itself might be setting them up for failure? That is precisely the question we're tackling today. In this episode of Mapping Healthcare, we'll explore the science behind human factors engineering. It's a scientific discipline where psychology meets engineering to help us design processes that make it easy for people to do the right thing. But first, let's start with a myth. It's the idea that focusing on human factors eliminates human error. That if we just train people harder, tell them to be more careful, then mistakes will vanish. And that's just fundamentally wrong. The scientific reality is that errors are inevitable. Everyone makes mistakes, no matter how smart or careful they are. So the field of human factors doesn't chase this impossible goal of perfect humans. Instead, it focuses on designing systems, the tools, the processes that are resilient to those mistakes that will inevitably happen, and systems that actually support our human abilities, both physical and cognitive. It's less about finding the perfect clinician and more about designing the perfect, or at least a much better, interaction between the clinician and the system. Our guest in today's episode of Mapping Healthcare is Professor Paul Bowie, Program Director for Safety and Improvement with National Health Service Education for Scotland. Paul and I talk about some of his work in the field of human factors and healthcare challenges that could be tackled using some of these principles. The views expressed on the show are mine and those of my guests. So Paul, welcome to Mapping Healthcare. It's good to have you here.
Thank you so much for the invitation.
You are the Program Director for Safety and Improvement with National Health Service Education for Scotland and are based in Glasgow, Scotland. So tell us briefly about your career path to what you do now. How did you get your start in human factors in healthcare?
Well, thanks, Ulfat. That's a long story. So I've worked in healthcare for around about 35 years, and I'm a non-clinician. So I've always worked in quality and safety advisory roles initially, but then more latterly in doing research and educational development from a human factors perspective in those areas. So my undergraduate degree was actually in the sociology of human work, which is a perfect starting point for segueing into human factors later in my career. You know, I did a master's degree in human factors and a PhD in significant event analysis. When I first started in healthcare, I worked as what was known then as a medical audit officer. So in the UK in the early 1990s, this was the first time that medical practitioners in the National Health Service were required to audit the quality of the medical care they delivered. And so I was brought in as one of 4 support officers in the region that I work in. That got me almost immediately into studying human work in healthcare environments, particularly alongside a whole range of different medical practitioners. And from that, we would do kind of risk and safety and kind of quality improvement type projects back in the early 90s. And we would used to work with some doctors in training who were keen to develop their careers. And so we'd publish together and established consultant staff, senior leaders would do also. And that gave me the buzz really to take a much more scholarly or academic approach to the study of quality and safety. In the last few years, maybe the last 5 years, I've developed what's known as a portfolio career. So I still have a role in the National Health Service in Scotland, but I'm also Professor of Human Factors at the University of Staffordshire in England, and I'm part of the education team to the Health Services Safety Investigation Body, also based in England. But the one thing that unites all three positions is this focus on building capacity and capability in the healthcare workforce around human factors approaches to improving patient safety, improving the well-being of the workforce, looking at the designs of technology, looking at the implementation and evaluation of those technologies, redesigning work systems and so on and so forth. And at the same time as doing that type of work, hopefully passing on good human factors lessons, educating the workforce in foundational concepts and tools that they can then apply themselves. So that's a kind of short summary of my 35-year career.
Yeah, and that's been a busy career indeed. I was reading about some of the work you've done and the papers you've published. They cover a range of topics that are really critical to delivering safe and effective healthcare. So let's talk about a couple of projects that you've worked on that could illustrate human factors principles and approaches. You worked with a team to look at human factors to support the design and testing of rapidly manufactured ventilators in the UK during the COVID-19 pandemic. This project was about the design, development, usability testing, and the operation of new ventilators as part of the UK response during the COVID-19 pandemic. So tell us about how the results of this work were used on the ground during the pandemic, how they can apply to health systems currently as well.
That was a fascinating time, Ilfa. This was in the very early weeks of the pandemic when, if you recall, certainly in the UK, it became apparent the way we understood the nature of the infection at that time that we were likely to require many more ventilators to help sick patients than we currently had. But we didn't have the capacity amongst established manufacturers to create the numbers of ventilators that were anticipated. And so what happened was that commercial non-healthcare manufacturers were brought in or volunteered to create these ventilators themselves using their own workforces. The issue is that they didn't have much experience in that sense, so we very quickly put together a team with the idea that we would have to provide guidance to these novice manufacturers of ventilators to ensure that the design of the ventilators accounted for the potential risks to both staff and patients in particular. We did that, and we developed some other human factors designed work procedures to support the implementation and use of these ventilators. But luckily for everybody, although we did all that work, it was never put to test in the real world, because the trajectory of the disease or the infection had changed as such that the requirement for the amount of ventilators that was anticipated no longer materialised. But it served, I think, as a really good example to the UK government and to other policy bodies about what the potential of the human factors discipline was in terms of, number one, a rapid response to a crisis situation, and number two, the whole idea of human factors design and its necessity in terms of ensuring that we looked after the well-being of the folks who would be using this equipment, and that the equipment in itself was, as far as possible, as usable, as user-friendly as possible, but also easy to follow and as low risk as is feasible. And as a matter of fact, that led on to a paper, again related to the COVID-19 pandemic, and this is work that we did in Scotland around the design of COVID-19 vaccination centres. So we went in and studied these centres and looked at, where the potential hazards and risks were, how we would have to design them to support the performance of the clinicians who were giving out the injections, as well as protecting the well-being of patients and others who were visiting these centres. And that was about purely the human-centred design to minimise risks within vaccination centres. Now, the great thing about that was this is an idea that we actually had prior to the COVID-19 pandemic, because I had been involved in so many safety investigations related to elderly folks and children who were turning up in family practice for vaccinations in community clinics and getting either the wrong vaccinations or double-dosed vaccinations. And so we knew there was both a risk and a design issue associated with that. So we took that very early learning and we applied it to the COVID-19 pandemic. And now that we have this paper published illustrating what we did from a human factors perspective, but also the fact that we developed good practice guidance on the design of vaccination facilities, which is generic and can be used in any care sector in any country.
So this really illustrates how you can rapidly deploy the human factors workforce in dealing with emerging issues and how some of those lessons stay on as we address future public health crises and medical issues that come up. Now let's talk about some work you did on another medical issue. So you and your team published a paper called Blood Sampling, Two Sides to the Story. And this was a research team that you were a part of where you looked at the variation in drawing blood for lab tests at 4 National Health Service Scotland hospitals. The study found that blood draws were influenced by the working environment, the equipment, and clinical context. So tell us about what you learned as part of this project and how it applies to improving care.
So this was a fascinating study, Ulfa, and what was done a number of years ago. There isn't a presentation I do at a conference or a workshop where I don't use a slide from this particular study because I think it gets across some key points about the nature of how we understand risk and safety in healthcare and what we do to try and improve things and mitigate risks. And this study, as I think, serves as a perfect illustration of that. So the study dealt with the ongoing issue of wrong blood in tube incidents, which is a global concern and has been for decades. And so when you look at the established research basis for this particular topic, you find that in terms of improvement over the decades, there's been a lot of what we would call behavioural type interventions. So, for example, you might say to a nurse or a midwife or a doctor in training that when you're in front of the patient and you're about to take blood, remember to do A, B, and C. So what we're doing is we're putting the onus on the clinician to behave in a certain way while they perform what is seen clinically, I would imagine, as a relatively simple task, drawing blood from a patient and sending it to a laboratory for processing. The issue is that when you introduce those types of interventions, they have some type of effect in a positive way for a number of weeks and then it tends to drop off. And that's what the evidence shows us. This is an important patient safety issue because unfortunately, as a result of wrong blood and tube incidents, we harm many patients worldwide and a proportion of them will also die. So it's both a patient safety issue, but it's also an efficiency issue because it's estimated that around 5 to 6% of these samples are knocked back by clinical laboratories because of a suspicion of wrong blood in tube. And you can imagine both the efficiency and cost issues associated with that, as well as, of course, what happens to a proportion of patients involved and the severe consequences there. So we introduced these behavioural type interventions, and as I say, they have limited impact, and then we're back to square one. So what hadn't been done before was, certainly from a human factors perspective, was for specialists to go in and study the work system, to study the care systems where these tasks were undertaken. And so we did that in a number of hospitals in Scotland. And what do you find? You find a mismatch between what it says on the guideline or the protocol and what actually happens in reality. So we assume that taking a blood from a patient is quite a linear, step-by-step process. There's 5 or 6 steps to ask the patient's name and date of birth and so on and get the basic details sorted out, and there shouldn't be an issue. However, when you study the work system, you find that clinicians who are undertaking this task may go to print a label with the patient's identification details on it. But you find there's no printer in that particular hospital ward. And so the doctor or the nurse has to leave the hospital ward to go to another ward because that's where the printer is. Or when they get there, they find that there's no labels in the printer or that the ink has run low and it needs to be replaced. And while they're there, one of their colleagues spots them and interrupts them and starts asking them about other patients on the ward who they have information about that they require to help them to do their work as well. So there's interruptions and distractions, some of them necessary, maybe some of them are not so necessary. And so we found a number of these issues. All of these issues that we picked up on, essentially, we have this idea of this simple clinical task that if you follow this logical procedure, there should be nothing wrong. But the reality is somewhat different. There's a lot of issues going on that essentially impact on your performance and your well-being. They cause anxiety, they cause stress. And so it's inevitable that things will go wrong sometimes. the key message here for those of our colleagues who work in the quality improvement world is that before you design an intervention, you must study the work system. You must understand the complexities of the work system as best as possible. And once you've got that sense of how it's actually done, then that may inform a more meaningful design of an improvement intervention. And I think often that's what's missing from much of our quality improvement projects. And that's one of the added value aspects of taking a human factors approach to it. So if we look at human factors as being about the evaluation and improvement of all aspects of human work, then it's really obvious to us that one of the first things you do is study the work system. So that single study has had lots of knock-on effects because it has shown up the kind of idea that we skate over the complexity of the work systems that we inhabit. And so when I present on this topic, I see lots of nods within the audience from clinicians who have undertaken that simple task, but also been affected by these suboptimally designed work systems that they work across.
And human factors has been around for a while. It emerged as a field I was reading during World War II because of the need to improve the design of aircrafts and other military equipment while paying attention to human fatigue, perception,
Yeah.
thinking, understanding, and usability. And since then, it's evolved and expanded into a range of settings to improve how humans interact with systems and the environment. You robustly study it and you have data and you adhere to study design principles, but I'm assuming there's still myths and misconceptions that surround human factors science and healthcare. So tell us about some of those.
That's a really good point, Alpha. I was speaking earlier, I estimate, and along with some of my other colleagues, that around 20% of my time in terms of engaging with policymakers and leaders and researchers and educators and practitioners is around getting some of them to unlearn what they think they know, what human factors is and what the approaches are. Because of the way that human factors was introduced to healthcare largely through the kind of anaesthetic surgical professions, where they looked at the need for what they called non-technical skills training, which came from crew resource management, which was an aviation type intervention. So the way that human factors was introduced was from the aviation world. But unfortunately, in most of the aviation world, what they call human factors training is essentially just looking at training people in leadership and communication and team working. All very, very necessary, but it's not a human factors intervention in the way that we understand it. The key thing here is that non-technical skills training is a behavioural intervention. And it's much needed because it was missing from medical curricula. We assumed that because you had great knowledge of medicine, that you'd be really good at your job, but well, we have to speak to each other, we have to communicate, somebody has to lead, we have to work in teams. And so it was great that we focus on these areas, but it's not the same as taking a human factors approach. Human factors is not a behavioural science. It sounds like it. It's a systems-based design science. So you can make a strong argument that human factors isn't about people per se. It's about designing for people. So we need to know about people's capacities and capabilities, but we also need to know about design standards and codes of practice, and we also need to know about systems approaches to understanding how they work and exploring and evaluating how they work in order to design work systems and technologies and interfaces in physical environments to make it easier for them to do the right thing. And that's what the human factors approach is. So its distinguishing features are, number one, it always takes a systems approach to any type of problem solving or the design of any type of intervention or the evaluation of that intervention. So that's what we mean by a systems approach, the consideration of the interactions, as you've mentioned, between people, the tasks that they do, the technologies they use, the physical environments in which they inhabit, how work is organised in terms of leadership and team working and shift patterns, and external influences like, clinical evidence, legislation, what the regulator says. All of these things are interacting and influence how work is done, either successfully or unsuccessfully on a daily basis. And so that's the systems approach. There's also, secondly, what we call a design intent. So we're designing for people. So we are drawing on different human sciences like anatomy, like biomechanics, like anthropometrics, organizational sciences like the management sciences, the safety sciences, and we're applying this knowledge to the design of tasks and work systems and technologies and physical environments. And we're trying to give rise to the third distinguishing feature of human factors, which is to jointly optimise what we call system performance and human well-being. So by system performance, we can be thinking about system safety, productivity, efficiency, reliability, and by human well-being, we can talk about patient safety. We can also talk about the welfare and the well-being of the workforce in terms of their stress and burnout levels and so on. That idea of focusing on both well-being and performance at the same time is a unique characteristic of the human factors approach. And we don't think that any other discipline in healthcare attempts that. Maybe a quick example might be you can co-design the best safety checklist for a problem that everybody agrees is necessary. You introduce it to the team, and then a month later, you realise that half of them are not using it anymore, even though they all agreed it was necessary and even though they were all part of the design and the implementation. Why are they not using it? Well, it's taken them an extra 10 minutes per day. And if it's taken an extra 10 minutes per day, then something else has to give. And so the checklist ends up being half used or not used at all, and people kind of give up and it's not sustained in practice. And that's because we haven't optimized both the performance issue, so it was necessary for patient safety, and the well-being issue. Then we needed to make it easy for people to do the right thing. And in this case, we haven't made it easy to do the right thing. We've added time to their day.
You bring up a really important point. There is a lot of investment in developing the evidence-based approaches in health systems improvement. But really, if you haven't paid attention to the human environmental technology interactions that can either sustain or prevent this work from going on, then essentially we've wasted all of that investment that you've made. So, looking forward over the next few years, Paul, are there any emerging trends that you're seeing that we should look out for in the field of human factors?
So especially in England and in some other countries like Norway, Netherlands, and Japan, we are seeing human factors approaches to safety investigation being taken seriously and being embedded in routine practice. And people who lead and conduct these safety investigations are being trained in human factors approaches to do that in a much more meaningful way. So that's certainly a trend in the right direction. One other obvious area is the growing interest in implementation of AI, of artificial intelligence. There's a famous paper by Bainbridge known as The Ironies of Automation. I think it's in the early 80s it came out. And so the ironies of automation is that every 5 years or so, and you and I will have seen this, there will be some new technology, some new digital technology or new way of doing something which is going to be a panacea and it's going to solve all our problems. But unfortunately, it's never as good as it's made out to be. But that doesn't stop a proportion of us falling for the belief that it will be. And so we see this in a cyclical nature, not just in healthcare, but in all work sectors. And that's why it's called the ironies of automation, because yes, we will get marginal gains from new technologies, sometimes significant gains from new technologies, but there's a downside to it. They always come with different risks, additional risks, some of which are predictable and some of which are not predictable. And they always need humans to oversee them in some way. And so that's one of the things that from a human factors design perspective, one of the guiding principles around something like artificial intelligence is that the humans should always be in control in some way or another so that they can have a finger on the off switch in some sense. There are other principles we can bring to bear in terms of things like understanding work is imagined and work is done, and what does that mean for technology. So a lot of what we see in terms of interfaces in healthcare, it certainly lacks human-centered design. And so we see lots of frustration, lots of work-related stress, lots of burnout amongst clinicians, simply often related to the different digital interfaces that they have to deal with. They have passwords for 9 different systems that don't speak to each other. Imagine having to negotiate and navigate that on a daily basis and the sheer frustration it can cause. And that's before we add in the fact that we're dealing with safety critical issues the vast majority of the time.
So those are some emerging trends that you've identified, Paul, that I'm going to look forward to. And I'm also looking forward to checking out that article that you mentioned, The Ironies of Automation by Bainbridge. I haven't read that. As we wrap up each episode of Mapping Healthcare, we talk about the place that our guest lives or works in. And you live and work in Glasgow, Scotland. This is a port city in Scotland's Western Lowlands. and it's famous for its architecture, and it's a cultural hub and has a thriving music scene. So tell us about a couple of experiences or places or foods in Glasgow that someone new to the area should check out.
So Glasgow is a fascinating place in the way it's evolved in the last 20, 30 years. So there isn't just one Glasgow experience. You can look at the different areas of Glasgow. So for example, there's a city centre area. Just off the city centre, there's a Merchant Square area. All of these places are fantastic for shopping and for restaurants and for the architecture, as you've said. But there's also the West End, where Glasgow University is situated, and this is much more bohemian. Some fantastic green spaces and parks, some wonderful restaurants there, lots of different music venues. Glasgow's also very famous for its football teams. And as you know, there's quite a significant rivalry between Glasgow Celtic and Glasgow Rangers. Visiting their stadiums is something might be worth a while for a visitor who's got an interest in football. To walk about Glasgow is very straightforward. Maybe other than the weather. What that means in Glasgow is you can get the 4 seasons all in one day. So if you don't like the weather, just wait 20 minutes and it'll change. Yeah, so I would encourage anybody who's interested in coming to Scotland, don't just go to Edinburgh. Glasgow's only half an hour away from the beginning of the Trossachs and the Highlands and all the magnificent scenery that's there.
Yeah, so seems like a fascinating place where there's something for every human, provided they dress for the weather, right? It was fascinating to talk to you today, Paul, to learn some more about your work in human factors. I appreciate the work that you do, and thank you for joining me today on Mapping Healthcare.
Thank you, Olva, and thank you very much for having me.
So that was Professor Paul Bowie telling us about why and how we need to think about the interaction between people, technology, equipment, and organizations to improve health systems. One example that comes to mind was work done in the United Kingdom to redesign ambulances to respond better to emergencies. It wasn't just minor tweaks. They looked at the whole environment in the back of the ambulance. Ergonomics, hygiene, how equipment was laid out, how people interacted with these elements to deliver care. The goal was to reduce physical and cognitive strain on paramedics and improve the care they could deliver under intense pressure. Human factors engineering isn't an optional nice to have. It's absolutely essential for dealing with the sheer complexity of modern healthcare, especially when we deal with digital health records, artificial intelligence, or coordinating patient care across different settings. It's time to integrate these human factors engineering principles into everything in healthcare. Not just hospital procedures, but national policies, regulations, and how health technology is designed. Especially now as we implement more complex technologies like artificial intelligence into healthcare. We have to approach these advancements through a human factors lens from the very beginning. The risk otherwise is that we just build sophisticated new ways to make errors. We could end up creating systems that enable smart people to make even more complex mistakes, just faster and at a larger scale. Thanks for tuning in. This was your host, Dr. Sheikh. You were listening to Mapping Healthcare on KDRT 95.7 FM. Please connect with the show on Instagram at Mapping Healthcare to share your thoughts and ideas for future episodes or guests. You can hear Mapping Healthcare around the world anytime on kdrt.org and wherever you get your podcasts. If you enjoyed this episode, please don't forget to subscribe and leave a review.